Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Mark Miller, and he's going to talk about musculoskeletal healthcare delivery, current problems and solutions. Mark has been a clinical practitioner for 34 years, is a faculty of the McKenzie Institute International and U.S.A, and has taught over 330 continuing education courses. Miller is the co-founder and vice president of clinical operations for Integrated Musculoskeletal Care, IMC, a global leader in musculoskeletal outcomes optimization. I hope you enjoyed the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Rangemaster, the most trusted brand for shoulder therapy tools. Available now on Amazon. Welcome to PT Pro Talk, Mark. How are you today?
I'm fine, thank you. How are you?
I'm doing well, and I'm excited for our topic today. So before we start, could you just tell us a little bit about yourself and your career? How did you get to where you are right now?
Sure. I've been a practicing physical therapist since 1987. In 1991, I was fortunate enough to spend some time in New Zealand working with McKenzie. When I came back to Canada, I started teaching a little bit of McKenzie, and I had my own practice. And it didn't take very long to start to realize that the way musculoskeletal healthcare was being delivered was actually, the system was broken. And sort of ever since then, I've set out to try to figure out better ways to approach musculoskeletal, continue to work with the McKenzie Institute and help develop programs within their organization. But then also, since moving to the United States, I've been steadily working at improving the systems of healthcare delivery around musculoskeletal disorders. And that's led me to Tallahassee, Florida, where we live now. And my partners and I have built a company called Integrated Musculoskeletal Care. And that's where I'm at now doing the majority of my work. And that work really entails training, standardizing, quality assuring clinicians that are associated with musculoskeletal, as well as going into payer systems like health systems, insurance systems, and as well as self-insured organizations, the large companies that employ the people of this country, and teaching them better ways to manage the populations that they serve in terms of musculoskeletal care. And so we bring in programs to help improve their situation, improve their beneficiary situations, and as well as continue to educate them about ways that they can improve the healthcare systems here in the United States.
That's awesome. And how would you describe the musculoskeletal healthcare delivery today?
It's very, very poor. In fact, in 2018, the World Health Organization, so I'm indicting the United States here, but really it's a worldwide problem. But in 2018, the World Health Organization named low back pain the number one chronic condition worldwide. They also named musculoskeletal as a whole the number two cause for chronic disability worldwide, as well as the number two chronic condition worldwide. And if you think about that, here we are in 2018 in the United States. Physical therapists are now coming out with degrees that allow them to call themselves doctors. You know, we've got chiropractors are much more mainstream medicine than they were when we graduated. They work at the VA. They're moving into hospital systems. When you look at imaging techniques and the refinement in surgical processes, you would think that musculoskeletal from a chronic disability situation would be improving. It would be declining as an issue. You would think that the spend for musculoskeletal healthcare would be declining as well. And yet musculoskeletal in a lot of environments that we go in and work, it's the number one medical spend. And according to the World Health Organization, as I stated, it's the number two chronic condition worldwide. And yet we've been, as the professions that are involved have been trying to improve themselves, they're not getting anywhere. In fact, we're losing the game. And so healthcare delivery in this country and really worldwide in first world is pretty poor.
And What do you think are the current problems of the musculoskeletal healthcare delivery today?
Well, there are a number of problems. So the first is that when someone enters the healthcare system for a musculoskeletal problem, they start at primary care. And primary care, therefore, makes the decision for roughly 70% of where people start out in terms of what they should do for their musculoskeletal problem. And yet, in over half the medical schools in this country, there is very little to no formal musculoskeletal training. So that's one issue, and we're working hard at trying to address that. Um, the other issue, there's two more in my opinion, and doesn't mean that I'm right. It just means based on my experience and what I've read in the literature, this seems to be a reasonable answer as to why. But it's the prevalence of derangements. You as an MDT trained clinician recognize what a derangement is. But when you look around the country, and I don't quote me on this, but I think there are over 150,000 physical therapists in the United States. And yet there are fewer than 7,000 that are credentialed in MDT. And so the concept of a derangement, a rapidly reversible musculoskeletal condition, is actually a foreign concept to most of the conservative care clinicians who address these problems every day. Another big problem is the prevalence of spine-related peripheral joint complaints. And if you read the last two, well, there's a third paper that just came out, but if you look at the last three papers that have come out, Richard Rosedale has been an author on all three of them, looking at the prevalence of spinal-driven peripheral joint presentations. They're actually quite high, and yet most clinicians, that being physical therapists, chiropractors, primary care doctors, pain management doctors, and orthopedic surgeons, aren't taught to fully screen the spine in the presence of a peripheral joint complaint. So when you put all those pieces together, right, the primary care doctors are the initial contact person in over 70%, and yet their training is minimal. The training for conservative care clinicians around the concept of rapidly reversible spinal and peripheral joint complaints is really not that good in terms of the training. And then the concept of a full spinal screen in the presence of all peripheral joint complaints is not a hallmark or a highlight of any conservative care clinicians' education. And I think when you put those three pieces together, you've got a perfect storm for a poor delivery system.
Absolutely. And now talking about the solution. So how do you think we can improve the problem of the training of the primary care physicians? I think that's something that's probably going to be really hard to change.
Yeah, well, so for instance, currently our organization, we are the preceptors for the TMH, which is our local hospital primary care residency program. People come from all over the world for this particular program. So how did that happen? Well, we were asked to come over for over a decade in terms to help foster their knowledge base around assessment and care for musculoskeletal conditions. Over time, that morphed into a full-blown program. And so my suggestion is this: we have got to somehow improve the education system around musculoskeletal assessment and care for primary care. That's one solution. And I think you know this probably from many of the podcasts you've done, but when we know we're doing something wrong in medicine, it still takes 40 years before it gets phased out. And when we know that something's actually correct and all the disciplines agree, it still takes 17 years before it becomes mainstream medicine, right? So it takes time, and it will continue to take time, but getting to the primary care group and formally training them how to better triage musculoskeletal, that's solution number one. Solution number two, and this could sound a little bit self-serving, but I've been at this for 30 some years. Solution number two is giving conservative care clinicians within the university systems a very good exposure to mechanical diagnosis and therapy, which is a cause and effect evaluation, right? It's a much misunderstood and misaligned approach. But if you look at the literature, the intertester reliability of the approach from an assessment perspective is beyond reproach. So that fits all the university's bills. Now, the validity in other words, the treatment process, and I'll get into this in a minute, the literature is up and down. Some literature is supportive, some not. And that's as to be expected. So if you're asking for the next piece, it's to get the universities, the trainers of these chiropractors and physical therapists to formally educate around mechanical diagnosis and therapy. The reason is because of the intertest reliability and its ability to use a cause and effect analysis to make decisions around the best care pathway, rather than the old anatomical models that seem to currently drive the decision making. Then the third part is it's not good enough to just train clinicians. You've got to develop standards and quality assurance programs that are associated with the patient's process, starting at the first assessment right through to discharge. And the reason is that if you don't have a standardization and a quality assurance program around training for conservative care clinicians, you can't guarantee the outcome. So you've got to consistently try to get people to the right clinicians. And then from there, you got to get those clinicians to get to the proper decision-making outcomes. Should these patients self-care? And if so, how? Should these patients be managed conservatively? And if so, how? Or should they be escalated into injection or surgical care? And if so, to whom and for what reason? And all of those parts have to be fixed. And I think they can be fixed if you can train primary care and you can train conservative care clinicians to better understand A, derangements, those rapidly reversible conditions, B, the prevalence of spinal-related peripheral joint complaints, and then do that to a standard and then quality assured around that standard with every patient. That's how you fix it. And that's actually what our organization does.
So now I have a couple questions about what you just said. So first, how can we make the primary care physicians, or like I would say, be open to a new approach to MDT? So how do you gain their trust, or how you prove results that they will be open? Like you said, you work for 10 years working with this organization, it looks like, but how do you gain these? Because that takes a long time and they have to be open to a new form of treatment and assessment, right?
Right. Well, that's a very tough question, right? And I wish I had the answer, because if I did, a lot of these problems would go away very rapidly. But I can take you down some pathways that would be maybe to some level of that might be able to help your listeners a little bit, right? So obviously you can do it on a local level, right? Keep clinical outcomes, be in constant conversation with the primary care physicians that refer these patients around these clinical outcomes. Schedule quarterly meetings with them so that you can go over these patients and show them the differences. Show them these patients that are scheduled for MRI, that are scheduled for surgery, that are planning on joint replacement, that are planning on spinal surgery, and take them through the outcomes, how these patients not only were managed, but what those outcomes were, and then follow these patients a year post-discharge so that you can show the long-term outcomes. The more you can demonstrate for the primary care groups that you're working with that their patients are in better hands if you screen through first, the faster you're going to be able to get them down better decision-making pathways. Now, we've built a program that trains primary care within the organizations with whom we work. Now, how do we do that? Well, 56% of all people in the United States are they're under a self-insured system. In other words, what that means is if you work for Ford Motor Company actually pays all your healthcare bills, not United Healthcare, not Blue Cross Blue Shield. It's Ford Motor Company does that. Well, Ford Motor Company has a vested interest in getting better health outcomes at a lower cost. So what they'll often do is build on-site health centers, and then they'll control those health centers. Well, we work very closely with those physician organizations that staff those centers. And we work very closely with the HR directors and the CEOs and CFOs of these large organizations who can make decisions around how they want these primary care physicians to be over and above trained beyond what they've came with. So what we do is we work with these self-insured companies, and we offer, and they agree to, let us train the primary care groups around better triage in musculoskeletal. That's another way to do it. A third way is you find these independent physician associations that are in some level of gain share or capitated arrangements. And what those mean is that if they save an insurance company or a payer so much money because they do a better job, then they get to share in the money that was saved. Or from a capitated perspective, they'll take on a set of lives. Say they'll take on 100,000 lives. The payer will give them X amount to manage that. Well, the number one spend will most likely be musculoskeletal. Well, if they spend all their money in musculoskeletal, they don't have any left over. But if you can come in and show them how they can get better outcomes at a lower cost, and then they get to keep the money that they didn't spend on care at the end, so there's a gain for them. They're very willing, actually, to learn how to better triage musculoskeletal cases. And the one thing I can say about primary care is they're very concerned about their patients. And they want to do the best they can. And they also recognize that of all their training, the weakest training they have is in musculoskeletal. And so what we found is that primary care doctors are generally happy. Not all of them, not all of them, but in general, they're happy to learn more about musculoskeletal and get involved in a partnership where their patients get better outcomes and they end up spending fewer healthcare dollars because it's to everyone's advantage.
Yeah. No, I think they're all great tips. I think the first solution is the hardest for sure, to get a good communication on a primary care. The second one, I think, is easier once you are inside the organization and they are committed to saving money. So they allow you to make more changes. So I think it's easier to access the physicians through this way, but hard to probably get the interest on the company and get their approval to do whatever you think is best. And I never heard about these physicians associations, independent physician associations. So that's a good thing to research, because if changes their financial situation, then there is incentive to do something different, right?
Yeah. The sad part is it often comes back to money.
Yeah.
But if that's going to be the driver, if that's going to be the driver of the positive change, then that's the way it is.
Yeah, absolutely. And then on the second solution that you talked about, putting McKenzie in a more formal way on the education of the PT students. So how do you think the MDT can get that space in a university to teach the method, at least introduced to the students?
Yes. And again, that's it's very difficult, right? Right now, what has proven most successful is to get to know the decision makers at the university level around curriculum and be willing to sit, discuss, educate, but also show data, be able to show large cohorts of data, be able to sit and discuss the literature. And frankly, another way that we've been able to do it is to show that if they come out with some level of MDT training, we have better jobs for them. And that's one of the things that my organization has been able to do. So Integrated Musculoskeletal Care, if a clinician graduates with some MDT training, we're more apt to hire them. We're also more apt to pay them more. And those incentives sometimes are valuable to portions of the decision-making teams at the university levels, because they want the people that they train to go out and get good jobs, and they want them to be able to make a good living. It's also part of what they do. And so when we get an opportunity, we'll go in and speak at the university level to those decision makers around the opportunities that an organization like ours can have for their graduates if they have some MDT training coming out.
Yeah, and that's the importance of having outcomes to show. And I think that's another thing that it's weak in general, is the outcomes tracking, which I think is really hard to be done. And that's the third solution that you mentioned before. So how do you think that the clinicians can have a better system of tracking their outcomes?
Right. So this is a difficult question for me, right? Because we're pretty far down the line in terms of that development. We have a proprietary database that we've built. What happens is patients come into our clinics. around the country. They fill out their metrics. They're in the database. And then they fill out the metrics every visit. And within 14 days of the third visit, our database has a built-in algorithm. And that algorithm can tell whether the patient is meeting an IMC standard of outcome or not. And then what occurs is if it's not, then it alerts our organization. And every week we have the clinicians with their list of patients that weren't meeting the standard based on the database algorithms. And they meet with a high-level senior trained tutor. And that's a weekly grand rounds process that we have so that our clinicians are on a never-ending learning curve, but their patients' outcomes can be guaranteed to any payer system so that we can go in and use our database for those purposes. And so we have a fairly sophisticated one. It's not something that's accessible by all of your listeners, but your listeners can very simply do pen to paper and then take an hour at night or at lunchtime or after work, and then go ahead and just put those numbers on an Excel spreadsheet. And they can do that regularly. I mean, if that's the lowest level that's possible, but it's very doable. And they can monitor patients' progress very simply using the Excel spreadsheets, because you can put formulas into the spreadsheets themselves, and that only takes a couple hours on Google to learn how to do that. So that's at a very base level. They can get online and figure out how to build a very simple database, or they can pay a programmer to create a little simple database for them. For that matter, I suppose they could even contact our organization and see what the availability of our database and the quality assurance around that is. You'd have to talk to our director of operations, and there'd be some fee associated with it. But those are the options.
Yeah. And what are the things that you think are important to track in terms of results to check if you are being efficient?
Right. So if you go into the literature, let's just take one index, for instance. So the Roland Morris, which is a well-recognized index for monitoring whether your approach to someone's lumbar spine problems is effective, right? Within the metric itself, there are standards that have to be met, so that minimally clinically important difference. You've heard of this, so that you can determine whether or not you are successful. So if I'm starting out, what I do is if I'm going to use the Roland Morris, I would determine within the scientific literature what the minimally clinically important difference is. And then I would see if by the third to fifth visit, if my patient was meeting that metric. And if so, I would consider my approach to have some value, and therefore I am being effective. That would be the play. So, they can go into the literature. There are a number of indices. They can determine which ones they think is best suited for their population, and they could monitor the outcomes.
And do you think you considered something efficient if you can improve with 3 to 5 visits? Is that?
Oh, that's very efficient. Yes, that's very efficient. If you look, Michael Porter, who's a healthcare economist from Harvard or Yale, but I think it's Harvard, came up with the healthcare value equation. And I think this answers your question. And what it is it's the clinical outcome divided by the total cost of care. So his point is that you really aren't bringing healthcare value to a patient or a payer system unless you get an excellent outcome. But that excellent outcome has to come with a reasonable cost attached to it. And that cost, because we're in a fee-for-service environment, is going to be dependent on how efficient and effective your clinician or our clinicians are, right? So if you get a good outcome, but it takes 14 visits and you need an MRI and they've had a lot of medication and maybe an injection, the healthcare value is really not there compared to you get an excellent outcome at 5 visits, they're discharged and they can manage themselves for the next year. That's a whole different level of healthcare value. So what is the key number? I can't tell you that. I believe in the last 10,000 patients we've seen, we average around 5 to 5.1 or 2 visits. We've proven healthcare value in that we work with some very large corporations, but I don't think you can say that everybody should try to aspire to that. We set our own gold standards within our organization, and we don't ask others to try to achieve those. That's just us.
Yeah. And so, for example, for the therapists, they want to show they are MDT trained, but they don't have this sophisticated way of tracking and they don't have a big database. Is there a way to compare your outcomes with the average? Is there like a number or like a database that you can compare to show like traditional physical therapy has an average of like 11 or 12 visits? And we as MDT providers, we average 5 to 6 visits. Is there a way to try to use some data from, I don't know if that exists, to try to show some value?
Yes. Yes. Look, I think you can find somewhere in the Medicare data that the average number of visits is 11 or 12. And if you're averaging 5 or 6, obviously you're much more efficient. Now, the next question is, but how are your clinical outcomes and how do they hold up over the year post-discharge? Because it's not just efficiency, it's also effectiveness. And so you've got to be able to monitor both.
Yeah, you should develop a way to stay in touch with your patient after discharge for, I don't know, do regular check-ins in a couple of months and see how they are doing to see if you are being effective long-term, right? Is that what you're saying?
The science tells us that regardless of outcome at discharge, say for lumbar and cervical spine conditions, that within a year, 50% are recurrent. And about 70 to 80% of those will re-enter the medical system. We also know that even if you've been successful or you appear to have been successful in a peripheral joint condition, that within a year, 60% are complaining again of problems with the same body part. We know this. Within certain organizations, we've monitored claims data. The one way to really find out if someone truly is better is if you have access to claims data, which no one does, by the way, so because it's proprietary. But if you have access to claims data and you follow a patient in the claims data, you can tell, because if you got them better, they won't show up in the claims data over the next year, right? They won't spend more healthcare dollars. But they could have left your office saying, boy, I think I feel pretty good. I'm good to go. And without your knowledge, they could re-enter fairly easily within the next year. In fact, our data shows that 18 months post-discharge, if they are examined and treated in what we call the community, in other words, the standard approaches to musculoskeletal healthcare, I think it's within 18 months, 36 or 38% are back in the medical system for the same body part. And that's regardless of whether they've had physical therapy, chiropractic, some pills, surgery, injections. It's a large number.
Yeah, it's still a big number. And I think then it comes the educational piece of how to maintain what you gain and posture and how to prevent that. I think it's also missing. And another curiosity that I was thinking is who actually tracks outcomes in the healthcare system? So like, do you have other like healthcare providers in other areas of healthcare, like tracking numbers to show efficiency? For example, doctors, other providers?
It's a developing process, right? So for instance, primary care groups that are in some kind of a contract will typically monitor certain outcomes, and if they monitor them, they'll actually get paid more. So for instance, if they're tracking a patient's A1C levels, this is their diabetics, and they're reaching out to their patients around the results of the tracking, they'll get paid more. So some outcomes are being tracked at the primary care level. At the surgical level, for instance, from a musculoskeletal perspective, hospital readmissions are tracked generally. Infection rates and mortality rates are tracked. Now, I don't think that tells you a whole lot about the efficiency of of the approach. However, it does offer some insight into, it doesn't even offer insight into effectiveness. I remember I was at a meeting one time and these outcomes came up, and the gentleman running the meeting said, I don't think those are outcomes. I think those are expectations. We don't expect our patients to be readmitted. We don't expect them to be infected, and we don't expect them to die. So, and I'm only bringing this up simply because it was a story, but those are the outcomes that orthopedic surgeons will track if they're trying to demonstrate their abilities somewhat.
I was curious to ask you if you know if the surgeons, if they track the outcomes after surgery, for example, an orthopedic surgery, because we know that a lot of times, for example, people have surgeries and there are derangements and will be simply resolved if they had an MDT assessment prior to. So I was curious to see if you know if they have a system to track that, to see if they are being efficient having surgery. How is the recovery after?
So it has not been our experience that that's a common thing that orthopedic surgeons do. Some do, though. I think you've probably heard of centers of excellence where insurance companies either build their own or they formulate centers of excellence around surgical centers. And then they're asked to keep short and long-term outcomes. And from an orthopedics perspective, they would use similar outcomes that we would, right? They might use an Oshwestry or a Roland Morris or a neck disability index or a WOMAC, but that's not a common thing that we've come across. But certain organizations may ask for outcomes, and therefore orthopedic groups will provide them. Now, we work closely with some organizations that do keep clinical outcomes because they work under the same guys that we do. I think one of the things you need to remember is, why do people keep outcomes? Well, in general, right now, if you look at the playing field as it is right now, they generally keep outcomes either to market themselves, right?
Mm-hmm.
Right. Oh, so it's a marketing tool. That's one of the reasons they would keep outcomes, so they can come back and say, this is what we were capable of doing. And the other reason they keep outcomes is because they've been asked or told to do it, right? But for us, the most important reason to keep outcomes is so that you can take that outcome, reflect back to the approach that got the outcome, and improve your practice pattern behaviors as a result. So if outcomes from our perspective are being used properly, yeah, you can use them to market, and you can use them to meet contractual obligations. But the main reason for clinical outcomes is to improve clinical process, to be able to go back and say, look, we thought we were doing a very good job in this particular arena, but either this particular clinician or the approach that we gave this clinician isn't working in this population of patients. So let's go back and figure out why.
Yeah. And I think would be like a dream if you could compare, for example, a surgery intervention and MDT with the same problem and show what are the rates of effectiveness in both different approaches. Because I think it's really hard when you have a patient that gets in the system and is told that they need surgery to actually try conservative care and give it a chance, and also have the chance to have an assessment with MDT trained clinicians. So I think that would be like a dream to be able to live in a reality that does that.
You know, it's funny that I just got off the phone with a telehealth patient of mine, and he's a physician. And the original phone call that I got was, I'm looking for the best orthopedic surgeon in the country to get my total hip replaced because of the problem. So I said, look, I can make a few phone calls for you. That won't be a problem. However, why don't you let me screen your lumbar spine first, then screen your hip to make sure that you don't have a rapidly reversible condition in your hip. Then screen your hip for another 10 days to make sure that you don't have a contractile condition within the hip that's causing your pain rather than your bony issues that you'd like to have replaced. And he said, that'd be fine. If you take a couple of visits, we'll do that. He had a lumbar spine derangement in his mid-lumbar spine that was the main pain generator. He was 40 to 50% better within weeks. He also had a small hip derangement residual. He's now 75% better. He's back in the gym. He's running. He's doing all the things he wants to do. Where I'm going with this is, If you take a pocket of 100 musculoskeletal conditions and you train primary care to triage, and then you standardize and quality assure conservative care clinicians around the MDT program and good patient management principles, this is what should happen. 92% of these are mechanical and rapid and resolvable. Not all rapidly, but the majority of them are. A couple of percent are going to need some level of injection. 2 to 3% are going to need some level of surgery. And there's a few that they should just be sort of moved out of the system and left alone. A small, less than 1% are going to be a red flag. So overall, that's what it should look like in the proper environments, right? So the question becomes, how do we compare conservative management to surgical management? I think that's not the right way to look at it. It's how do we get the patient to the most appropriate, effective, and efficient care? And how do you do that? And then if you do, every group has their own place in the system, right? Primary care with maybe a simple mobile app that, well, we've created that, but I don't want to get into that. But primary care with just some good information, they should be able to triage patients, and 50% of the patients that enter the medical health system should be able to self-care their own problem. That's what we found. The other half should then be examined to screen out any spinal derangements, any peripheral joint derangements, any spinal relation to the peripheral joint, and any remodelable connective tissue issues. That whole process should take no more than 10 to 14 days, ever. If that's not resolvable within that system and an image matches the clinical profile, then an injection or a surgery is in order. But each group has its place. And I don't think they should be compared against each other.
We should have clinicians that are trained to screen and have a good assessment. And then in the first few days of treatment, know how to classify and then understand if the patient is going to improve or if it's going to need another approach. And then with the ones that need another approach, what do you do? Do you refer to other specialties? Do you refer back to the doctor? What is usually the approach?
Yeah, so again, it depends on the relationship that you have, right? So if the patient has come over from primary care and the decision on your end is that this is most likely a chemically dominant problem and could do better in an injection environment, then the natural thing to do is call the primary care office, give them your findings, offer your suggestions. It really comes down to the primary care doctor to make that decision. If the patient came in off the street, in other words, it was a self-referral, then I would discuss what our findings were with the patient. And then we need to get them a referral over to whether it be a surgical consult or a pain management consult around injection. So once again, I think that's a circle back down to the primary care office and discuss the findings and to make decisions together as a team.
Yes, absolutely. And where do you see the musculoskeletal care in the future?
So what you're going to get is really a biased answer, because what our organization is trying to do is create what we think the future should look like. And really what the future should be is well-trained primary care in the area of triage musculoskeletal, well-trained conservative care clinicians in the area of cause and effect evaluations and sub-classification processes. MDT is in the forefront of that. Then once those pieces are in place, standardization and quality assurance around those groups so that you can maximize the effectiveness, maximize the efficiency, and get better outcomes at a lower cost, which meets Porter's healthcare value equation. Then on top of that, build centers of excellence around like-minded clinicians in the pain management sphere and in the orthopedic surgery sphere, so that the patient is moved always to the most appropriate care at the most appropriate time towards the most excellent outcome that is not only short-term but long-term. And that's how I see the future of musculoskeletal medicine. That's why we're trying to create.
I think that's fascinating what you're doing and what you're building and creating. And I wish that could involve a big amount of clinicians and involve a good part of the country. So we have this process a little bit quicker because everything moves so slow. And I think that would be awesome.
Yes.
And I know you also do training for MDT clinicians, correct? So for
Yes.
the MDT clinicians that are listening to the podcast, they can sign up for the training on the IMC platform. Is that right?
So, well, it's not exactly like that, but we are glad to talk to anybody who's interested, right? So, because
Mm-hmm.
we're always trying to build a network, and one of the problems if you build a network too early prior to bringing business, people go through the training, they get excited, they're interested, and then they slowly fade away because there's no business for them. You know, when we
Mm-hmm.
talk about how do you create an environment that's going to make what we're talking about happen much, much quicker, is you get the payer to demand it. And that's the other part of this that we really haven't talked about much. We've gone to the self-insured industries of the country. We've we've gone to, and we continue to. We go to the brokers, those individuals who are interested in innovative healthcare for the right reasons. We go to the thought leaders and get them to continue talking about how to improve and create value within medicine and musculoskeletal healthcare. So we're going to all these different groups because if the payers actually demand a certain process, that's how you're going to rapidly get the clinicians that are supplying to change. And that's what we're doing. But we're not doing it just because we're out there marketing. We're not really marketing. We're taking them clinical outcomes data that is accompanied by economic outcomes data. And what we're finding is that no one out there that we can tell is getting as good to excellent clinical outcomes, and no one we can tell is getting economic outcomes that they can prove. We've put the two together, and we're not saying we're the best. That's it, or this is the only way to do it. But we can't find anything out there that can say these two things. We can go into an organization and we can contract and guarantee musculoskeletal outcomes. We guarantee that per 100, this is what's going to happen. And we can guarantee that they'll save this much money as a result. So we guarantee the clinical and we guarantee the economic. And we do that through these organizations. And then they demand that the clinicians who they are associated with can do this. And we think that's going to create that level of change that you're asking.
And once you show them that, it's easier to get their buy-in to join the IMC program.
Mm-hmm. That's right.
Yeah, perfect. Yeah, I think that's the dream. I think what you're doing is fascinating. It's how
Well, thank
many
you.
years in the journey?
This journey has been 35 years.
Oh gosh, it's a
Um,
long time.
yes, yes. I started keeping clinical outcomes back in the early 90s. And I'd love to tell you it was because I was a forward thinker and I was far ahead of everybody. No, I was a very frightened young man. I was frightened to go into the clinic because I knew I wasn't that good, and I was frightened to get on stage because people would throw things at me. So I started keeping clinical outcomes so that I could talk a little bit about what we're finding, and so I could improve on what I was doing, and that's really where it came from.
Oh, that's awesome. And transition to the final questions. What is your favorite resource of information? Any books or specific papers, studies that you like?
Right. So I hate to do this to you, but my favorite source of information is the continual clinical outcomes that we see every day. I'm the chief clinical officer of this particular organization. I see the clinical outcomes. I see them per clinician, per clinic, per organization, per company, and I use those to make a lot of decisions around improving training methodologies. If you're asking where to go, you know, you can Google any topic and find anything you'd like. And so it's very difficult for me to try to steer you to one category, of literature over and above any other. Because what people tend to do is they try to find literature to support their opinion rather than trying to find literature to help improve their process. And so what I would say is you can find anything you want out there. And really, you should apply it and watch what the clinical outcomes are so you can figure out whether what you've just applied is generalizable. But I think go in with an open mind with the hope to change and improve what you're doing rather than go into the science hoping to find or prove that what you're doing is the best. You see what I'm saying? So that
Yes.
would be my suggestion now. I think everybody should read McKenzie's textbooks. And I mean, everybody should read them. They should read the lumbar and cervical text, and they should read the peripheral joint text, and they should apply principles. I think everybody should get MDT trained and then make clinical decisions from there. I mean, but some of your viewers would say, well, of course he does. He's faculty with McKenzie Institute. I think what I'd like to say is the reason I'm faculty with McKenzie Institute is because my years of work and research have proven that of all the approaches to assessment and care for musculoskeletal, Robin McKenzie's approach has been, to me, has been the most successful. And frankly, I haven't found anything in the literature that's actually even come close. So for what it's worth, our data, our ability to go in and guarantee clinical outcomes. By the way, guarantee means if we don't meet those outcomes in the next 8 to 10,000 patients we see for you, if those outcomes aren't there, we'll pay you back. If we don't save you this exact amount of money or more, we will pay you back. We've never had to do that. And frankly, that's a good thing because I don't think we'd be able to do it. We wouldn't be able to afford it.
Yeah, well,
Don't tell them that.
it's risk-free for them, so why would they not try, right? There's no reason why
Exactly.
not to try. You make so easy that they're like, yes, let's do this.
Well, I'm not going to drop names, but we have been fairly successful in gaining clients over the last few years, which does bring up a point, and I appreciate you indulging me here. What we'd like to do is have clinicians with some MDT training join us in Florida, and really preferably to come to and train with us and see patients and work with us for a couple of years. And then as we continue to expand our organization around the country, then a lot of clinicians have come, worked with us for a few years, and then moved on to different areas of the country where we've got these situations where we've got on-site health centers, or we've got a few of them that do telehealth from home for us because our telehealth business has grown so much. And so if there are clinicians out here with some MDT training that would be interested in joining an organization like ours, we're always looking to try to bring people into Florida, in Tallahassee, to work with us. And what's interesting is a lot of people do come and then think they're staying for a couple of years, and then they end up staying because they like it here. So.
Yeah, and it's a great opportunity to improve your skills since you're having these rounds and education. So it's a very good opportunity for the PTs that want to improve their MDT skills as well.
Absolutely, yes. Everybody in our organization is certified or diplomaed in Florida. That's not fair. There's a couple of clinicians that are working on getting certified, and they'll be certified this year. But every patient that they see is quality assured. They have weekly grand rounds with our highly level, and I think all our grand rounds tutors but one has a diploma in MDT. Some are faculty, and that's a growing and developing system as well. So yeah, it's a great environment for those individuals that would like to get on a fast track learning curve around their MDT skill set.
Yes, absolutely. And what would be the best advice you give to the clinicians that are starting their careers?
So those that are starting, always be critical. Be critical of everything you do and say. Make sure that when you're with a patient, that they're part of the decision-making process around how you assess and care for them. It'll improve your compliance level. It'll improve your rapport. It'll decrease your dropout levels. Get MDT trained. You're going to get there eventually anyway, in my opinion. Why don't you start now? But again, the key is be critical of your outcomes so that you are on a never-ending, continuing clinical development curve. You owe it to the patients you're with. You owe it to the individuals that are paying the bill. You probably even owe it to the university that took a chance on you. And for all those individuals that didn't get into PT school, you were the one that got in. So make sure you never stop getting better.
Yeah. And what personal qualities or abilities are important to become a successful physical therapist?
There's many. You have to have an analytical mind. You have to be able to take information that's coming in, analyze it, put it together, not let your biases take over, not even let your experience take over, but let the information in front of you take over so that you can make good clinical decisions. So you have to be analytical. Number two is you have to be personable. Now, you don't have to be a guy or a girl that can get on stage and tell jokes, but you have to be personable to a point where people feel they can trust you and they can feel relatively comfortable with you. Because if you can't get them to trust you and you can't get them to feel relatively comfortable, there's a good chance they'll take what they think is necessary and they'll quit coming. And the reason they'll do that is because they're not convinced that you really actually know everything they think that you need to know. So you have to be able to build relationships with patients and produce trust. But if you're analytical and you are either naturally trustworthy or you can at least create that environment, you'll do fine.
Yes. And Mark, I appreciate so much you taking the time and share with us all your knowledge. It's been awesome spend this almost last hour with you talking about the problem solutions. I think it's very exciting, the future, and I think all the changes and growth and everything that you're doing with your company is amazing and fascinating. So thank you so much for taking the front for all of us physical therapists and MDT trained clinicians. So I really appreciate all that you're doing and all the information you share with us.
Well, it's my pleasure, and thank you for having me on and doing your part to get the word out. So I enjoyed it, and anytime. You take good care of yourself.
Thank you. And just for people that want to know more about you or contact you, how they can find you?
They can find me at mark.miller@imcpt.com. They can Google IMCPT. They can Google Integrated Musculoskeletal Care. They'll find me. I'm pretty easy. They can actually go to the McKenzie website. I'm sure there's something on there about me somewhere. So I think they could probably do it that way as well.
Awesome. Thank you so much.